Hello, and welcome to the Dr. Money Matters podcast, the show where we discuss important financial topics that were never covered in med school. I'm your host, Dr. Tarang Patel. Today's episode is actually not about personal finance. Rather, it's about an alternative practice model. I talked to Dr. Josh Umbehr, a primary care doctor in Wichita, Kansas, who founded Atlas MD, a direct primary care model in which patients pay a subscription for continued primary care coverage. It's a great episode. I'm really excited to present him. Dr. Umbehr was recently interviewed on Fox News, and he's been a leading advocate of this type of model. And whether you're able to change your practice to this type of model or whether you stay in a traditional model doesn't really matter. It's just good to know that alternatives to traditional practice are out there. Once again, thank you for subscribing to this podcast. I hope you're enjoying it, and I hope you continue to share this podcast with your colleagues and anyone else you think would benefit from the topics being discussed. And please continue to send topics for suggestion. You can tweet me at Dr. Money Matters, or you can find me on Facebook, Instagram, or just send email topics to comments at drmoneymatters.com. That's all spelled out. Thanks, and enjoy the show. All right, welcome to another episode of the Dr. Money Matters podcast. Our guest today is Dr. Josh Umbehr of Atlas MD in Wichita, Kansas. Dr. Umbehr is a family practice physician who went to med school at the University of Kansas, did his family medicine residency at Wesley Medical Center in Wichita, and founded Atlas MD in 2010 with his partner, Dr. Doug Nunamaker. Atlas MD is a direct primary care practice. Welcome to the show, Dr. Umbehr.
Well, thank you for having me.
Can you just tell us a little bit about your background, what made you want to go into medicine and primary care?
Yeah, I had, for as long as I can remember, in our small town, the classic family doctor that we could go to anytime we scraped something or sick or injure ourselves on the farm, and just loved that idea of it. And then my dad ran a business, and I saw how well that could work. But then when I was in undergrad shadowing physicians, I saw the medicine that I loved, but this very cumbersome business model that seemed to overshadow everything else. And so that was in 2000. And from there on through undergrad, med school, and residency, was looking for ways to do it with a better business model or outside of insurance, and came across a few mentors in the process, and eventually took the best of both worlds from that membership model, insurance-free, to the fee-for-service, insurance-free model to make what became our practice, or direct primary care.
And so you started this, as you said, in 2010. Obviously, it's been doing pretty well for the last 7 years. Can you tell us a little bit about the challenges you faced when you first started this model?
Yeah, the biggest one was we had no idea what we were doing. Yeah, in a lot of ways, like the tale of the emperor's new clothes, we were the wise fool who could point out how broken the rest of the system was. But in a lot of ways, we didn't have any bad habits. We didn't know what we couldn't do or what we had to do, and really left us open as a blank slate. We knew enough that the insurance model was inefficient at best. So coming out and saying, well, if we're going to do a membership, how do we make that mean something? How do we make that valuable? And working with a few business advisors said, well, make it different, make it new, make it exciting. What are the pain points or friction points? And for both the doctor and the patient. And that's why we were able, I think, to have a clear line of sight from problem to solution. If we were asking the right questions, we'd get the right answers. What would make this better for patients? How do we make this more affordable? How do we improve access? And then all the other stuff really fell to the wayside. If we're not billing insurance, because that doesn't make a lot of sense for strep throat, for heartburn, for depression, for most of what we do for family medicine, then that freed up a lot of time. And if we say, well, if we're going to prescribe you something, then can we help make that more affordable? And just kept asking the next question. And from there, it turns out, Kansas is one of 44 states that allow physicians to dispense wholesale medications. And that was an option that had always been around. We didn't change anything, but by using a tool that other doctors weren't using, we could really have a huge impact on our patients' cost of care. And we could apply that going forward to lab testing and pathology and imaging. And we just kept plowing through it until we got to a very efficient and valuable model.
Good. So you mentioned the medication. So give me a specific example. Like, how does that work? A patient comes to your office, you prescribe them their hypertension medication. They actually fill it at your office?
Yeah, just like doctors have ordered flu vaccines and lidocaine and gauze and gloves, you can order medications. And in a really interesting way, we get them wholesale at the same price that pharmacists do. Maybe not at the volume discounts of Walmart, but even though Walmart buys it for less than I do, I can sell it for less and still make a profit. And like 1,000 Lasix, Walmart will do 90-day supply for $10. I get 1,000 pills for $8. It is a 10x improvement over the status quo. And I'm sure we're paying more than Walmart is per pill, but because the membership model for care allows us to add value that doesn't require a significant return on investment there. For me, that's the marketing budget. When a patient picks up their medicine for 33 cents and actually just goes to their credit card on the monthly invoice, they're shocked. They tweet that out. They're thrilled. When they were getting their Imitrex for $100 a month and I can now get it for $3 a month, they're ecstatic. You saved them a ton of money, and that means something to them. Or their blood work, a CBC is $1.65. With my 10% markup. Damn capitalism. And now they don't have to worry about it. They can get health care with a different financial algorithm. Good, if I need to check something, then I don't have that FOBB, fear of a big bill that they talk about in healthcare. So, we have the meds here. We order them. We count them. We just, put them in the bottle and hand them to the patient. So they walk out the door with their medicine, and they don't have to pay at the time of service. So it makes it even easier. Okay.
And you don't have to have a separate pharmacist to do that because you're ordering this under your license.
Right. And for most of what we do, we're very familiar with those medicines. It's standard medicines. And really, if you're licensed to prescribe it, the dispensing side is a lower level skill.
Right.
Knowing what to prescribe is the hard part. Counting the pills is actually quite simple. I have a machine that does it. So.
Right. Okay. Interesting. It's something that I think it's surprising that when you said 44 states allow it, I other than you talking about it, I can't think of any time I've heard of a physician practice doing it. So that's interesting. Now, I'm sure that they are there, but it just doesn't seem to be a very common phenomenon. So that's a tremendous efficiency that you guys have found to improve your patients' costs and convenience. So that's great.
Yeah, it was a value add that pharmacists and doctors didn't know we could do. And I forget how exactly we stumbled across it, but just looking for solutions for our patients, which is, I kind of put that fault back on the doctors. Is we complain a lot about the high cost of care, but we don't go out and actually fix it. And I think that's for a variety of reasons, but maybe more importantly, we want to think that healthcare is not a business, and it absolutely is a business, and we should take great pride in that. With Apple and iPhones, I have a supercomputer in my pocket that gets better every year at the same or better price because of good business. And so when I talk to med students, I say, if we take our oath seriously of do no harm, it has to include do no financial harm. For a poor, low SES patient working a $10 an hour job, if I can save you $100 a month on your migraine medicine, great, I've taken care of your migraines, but really even better, I've given you a good chunk of money back for you to spend in your life in some other way. So we're bringing value back to the system instead of pulling it out.
Right. Now, we had mentioned, so your practice is a direct primary care practice, which is an evolution of, I guess the previous term was concierge model. How does that differ? Because I think the traditional mindset or image of concierge is, a very expensive practice catering to, the richest people.
The 1%.
Exactly.
It started that way. And like a lot of innovation, it starts expensive and then trickles down. Airbags were only in high-end cars, and then they finally became more and more affordable. So now they're in all cars. And the old version of concierge medicine is that $25,000 per person per year type model, and they still bill your insurance. So I think that's the key difference is this isn't just a model designed for a few doctors, 1% of doctors to take care of the 1% of patients who can afford something outside of a broken system. Direct primary care is an affordable membership model that's insurance free because we don't need insurance for affordable things. That's a standard play. And if we can make healthcare, primary care affordable for the masses, we can have a huge impact on the rest of society. In terms of our direct care model is $10 for kids, $50 per month for most adults for unlimited home visits, work visits, office visits, technology visits, cell phone texting, email, video chat. We have no copays for anything in the office ever. Any procedure we do in the office is included free of charge. So that includes EKGs, stitches, biopsies, joint injections, ultrasounds, DEXAs, spirometry, Holter, urinalysis, rapid streps, minor surgical procedures. But those are all actually affordable things. An EKG cost me 36 cents, hard costs out the door.
Wow.
The coffee in the waiting room is 60 cents a cup. So, we can affect this, but then we can take all that value, go to an employer, decrease the employer's insurance premiums by 30 to 60% in the first year. We've had some employers decrease their total cost of their health insurance by 75% over 5 years as they've grown. Well, if we could do that for even a fraction of the small businesses across the country, we would have an economic boom. It really would be an important game changer. So the direct care model is more than just concierge medicine for a few people who can escape a broken system. We want this to be the affordable solution moving forward.
Okay. So in that respect, as you said, you can see this as more than obviously just the 1%. How has your practice grown since your opening?
Well, when we started, it was one doctor and no patients. We were hoping to grow at 10 patients a month, but projected adding doctors to be several years out. We were fortunate enough that I think we set our value proposition correctly, a very low price, high value model. We were able to grow at around 30 patients a month for the first 9 months and bring on Dr. Doug, my partner, full-time away from the hospital within those 9 months. And then we've added a doctor about every year. So we're about to add our 6th doctor to our practice locally, and we have 2 locations. But we've helped over 230 doctors convert to this model in the last 2.5 years. So we've seen a lot of growth in the movement overall.
Oh, okay. So you've educated physicians, I think, all over the country. Mm-hmm. And I know you speak about these things. You also host your own podcast and inform physicians. You teach medical students. Obviously, there must be a high level of interest in doing this, but yet we continue to see more and more physicians going into employed models. This is kind of still an out-of-the-box type of thinking. How do you convince more of our listeners, future physicians, that they too can do this?
I think it is that evolution. When we started 6-7 years ago, there were a single-digit number of doctors doing a similar model, and no one thought it would work. Now, 6-7 years later, we've had the appropriate amount of time to develop the model, grow it, show the success and the opportunities, and doctors during that same amount of time have only seen insurance costs go up, their paperwork go up, their hassle factor, their burnout, and all the bad is increasing, and their incomes are decreasing. Their enjoyment is decreasing. So before, they knew the system was broken, but they never saw a successful example of another option. Now, they increasingly see successful examples of another option that really maybe sounds too good to be true. more care for more people more often at a lower price point, while the doctor does less work in terms of paperwork but makes more money. Those sound like a contradiction, but business is great at finding and fixing contradictions. I want a bigger, better, faster phone that's thinner and a longer battery life. Those things are competing against each other, but every year I get just that. When we can reach into the ether and find those cost-saving solutions like wholesale meds or wholesale labs or insurance premiums, bringing the cost of care down so far allows us to sustain our income or increase it while enjoying the practice of medicine. Because that is now attractive compared to the status quo, and there is a believable, structured, successful alternative, now doctors are really starting to evaluate that. The AFP has a study that says 35% of primary care physicians would consider moving to a direct care model in the next few years, which is up from single digits just even a few years ago. So success begets success, and doctors are increasingly aware the system is broken. Now it's MACRA and MIPS, and it'll be something else soon, and it's just not working. So I think that's why we're seeing so much enthusiasm for the model.
Right. And so one of the concerns that obviously physicians have had is, like we mentioned, the original concierge model was the 1%, but they feel that, okay, I don't have that panel of high income patients, but you're talking about this is a regular group, mixed spectrum of patients, and yet it's still financially viable. How is this model compared for you and your practice financially versus what, your traditional employed or regular private practice physician has done?
Well, most of the doctors I've hired for our practice were coming from a hospital-employed, bureaucratic, painful, frustrating model, salary at $140 a year to see 30-plus patients a day. With us, they're salaried at $200,000 per year and see on average 6 a day. So quality of life's better, charting's better, professional autonomy is better. There's fewer hands in the cookie jar. We don't need the administrative burden of a hospital to run a family practice clinic when you're doing an efficient clinic model. It's easy to think you need all that if you're trying to comply with MACRA and MIPS and quality reporting and yada, yada. You're quick to go into the employment model if that's what you think you need. But when you realize there is a different way, then and our patient base really does run the gamut. I would say more of our patients are blue-collar employers working with us for those savings because they need the savings more. I mean, in all due respect, you save a rich person $100, that's great. They appreciate it, but it's not valued the same way as a lower SES patient that you save $100. A single mom working a call center job, she has to ask for permission to go to the bathroom, let alone go to the doctor or take one of the kids to the doctor. Well, now that she can call, text, email her doctor any time of the day and get medicine at a fraction of the price and not have to pay a copay or not have to have a functional car and gas money and drive across town just to find out that that's a rash or a virus or heartburn or depression or anxiety, then Zoloft 76 cents a month with us, not $12, $15, $20 at the pharmacy. That's a huge change to their quality of life, their outcomes, etc. So I think when you start to understand all the moving pieces of the model, the poorer and sicker you are, the more this benefits you. The more you need these types of savings. It's kind of ridiculous what we do in the current model is A, you can only see the doctor if you have good insurance. B, when you do, you have to get off work, you have to drive across town, you have to have money for a copay because Lord knows no other practice will see you if you don't have your full copayment right up there.
Absolutely.
It's almost let them eat cake. You're poor, but you have to come to the office and for all that you get 7 minutes with the doctor, of which you're lucky to get 2 or 3 minutes of their actual attention. There is a better way.
Right. Do your patients, obviously they come to you for primary care basic services that you've already described, and that's great. They still carry their own insurance, correct?
Well, about a third of our patients have no insurance.
Okay.
We thought that would go down even or during the Affordable Care Act. But what we found is those working poor who didn't make enough money to get enough of a subsidy to make the insurance worth it. Mm-hmm. And then other people who just said, look, I'm spending $800-900 a month on insurance I'm not using. I'll just keep that money and take the penalty. Now there's no penalty for 2016. And again, what they're realizing is the majority of care that I need, I can get from a family doctor doing this model. If you need a skin biopsy, we can do that. And the pathology fee used to be $300 that we have down to $40 now because of mailing it to Cole Diagnostics in Boise, Idaho. But now you have a Mayo-trained dermatopathologist looking at something for a fraction of the cost. An A1C to screen for diabetes is $2.25. That's an affordable level for patients who are at any level. And then if they do have diabetes, I can treat it with 1,000 metformin for $14. And now they say, well, why would I insure all of those pieces? Instead of go to the ER for stitches for $1,500, I'll go to the doctor who does them for free as part of my membership. This works out for everybody, not just us, in a really elegant way. What we've done is put the patient first in all scenarios. But then the downstream benefits of those are system-wide. If I protect my doctor-patient relationship first and foremost without worrying about anything else, good outcomes still happen. Because if I protect the patient's money, I protect the employer's insurance. If I protect the insurance, then I keep premiums low year to year. And so then if premiums go down year to year, the patient saves more money, the employer saves money, the insurance saves money, the system benefits, all while getting maximal level of care, no rationing, etc. So, yeah, we see a lot more patients comfortable having less insurance or high deductible type plan. And this is really changing their shopping patterns because the current system, we say, we need price transparency, we need consumerism, but you go out there and it's really hard to be a good consumer of healthcare. But then in our model, we've done that work for you. You feel more comfortable having a high deductible plan because labs aren't $1,000, they're $10.
Right. And so going along that, I mean, you mentioned your like the skin biopsy, that tremendous example there. What do patients do that then do need, specialist referral? Do you have partnerships with specialists in Wichita that can kind of give them a better deal on their services as well?
Yeah, there's a couple of great ways to do that. One, just local negotiation. We have that for all kinds of things, physical therapy, occupational therapy. Our ortho group will do casting for $50, x-ray, 20 to 40, ultrasound 100, CT 200, MRI 400. There's a service, RubiconMD.com, which is an online physician consult service. So I can go in and get a pediatric endocrinology consult. We don't have one in town, but I can go get one because that's an information type service. Well, we live in the information age. Why do I have to be geographically located to an excellent pediatric endocrinologist when I can just buy one online?
Right.
Yeah. And I can do that for the patient at a cheaper price point and get a better outcome faster. Their average response time is less than 12 hours. What they actually know is the response time is less than 6 hours, but the docs tend to do it at the end of the day and then open it the next morning. So, response time is quicker. It's just the doctor waiting to open it, for the workday. But that is smart technology making the world smaller, faster, better, cheaper. And then, of course, use the insurance whenever. Some of those questions, I would say, not trying to be coy or dodge a difficult question, but we do what we can when we can. There's so many overlapping gray areas in healthcare. I had a patient, he had a basal cell carcinoma, kind of mid-pupil down on his cheek, and take it off, $40, free procedure, we're done. Clear margins, no problem. Cancer cured. Had that been an inch over on his nostril, we know that's plastic surgery every time.
Right.
So there are those nuances there, but when the insurance company knows that 85% of people at the $3,000 deductible won't reach that in a given year, and 95% of people with a $5,000 deductible, and they won't reach that in a given year. And that's in the current broken system, high prices. Most people are just never going to hit their deductible with average care. But if they do, great. I mean, we want everybody to have insurance. We just want it to work. We're not anti-insurance or anti-government. We are pro-efficiency, pro-value. But the insurance companies we've worked with the longest tell us that their profit margins are 4 times higher with us than with their next best plan because of administrative efficiencies, and we're outcompeting Walmart on medicines and et cetera, et cetera.
Wow. Yeah, that's amazing. And you're absolutely right. Health in every other field, efficiencies have been kind of wrung out of the system or have been done so more significantly than healthcare. So it's great to see a company and a practice such as yourself doing that for medicine. Although I'm sure for a lot of our older listeners or people who've been in practice for a while, it's a scary thought, but this is the future. So tremendous.
And it's easy for the older doctors to do, too. They can convert their practice over very quickly, in some ways even easier than starting a practice. They already have a patient panel. They already have exam tables and a location and phone numbers and staff. So we really worked hard to make this good for everybody in the system.
So let me ask you this. Now, you mentioned your average physician sees about 6 patients a day, but you do mention that there's unlimited home visits, unlimited technology visits. So what is just kind of go through a given day for yourself for me. When you come into the office, what time do you generally leave? How does that work for you?
Sure. I usually come in 8 to 6, but I'm doing other business stuff, running the practice. So most of my docs would be really 9 to 5, maybe 15 minutes before or after, and probably see 10 patients a day through either the 5 or 6 in the office and another 5 or so phone call, text message, email. Some of those are just simple things like refills. Maybe it's a depression, anxiety, heartburn, phone call or email, or that conversation can now extend over days as patients are thinking about it and deciding on options. So then probably 2 or 3 patients of that will need labs each day. So the next day you're returning those labs, and it takes us less than 24 hours to get those results. So the first thing I do is get all of those things to the patients for customer service. And yesterday I ordered CT for $200, had results before the end of the day, so we knew what was going on. So it's that you're managing the office, and I think every family doctor knows this, but it's impressive how much uncompensated care is done outside of the exam room. You might have a normal day until a kid with appendicitis, and now you're juggling getting the ultrasound, maybe talking to the surgeon, get some stat labs, call mom, call dad, those kind of things. But you're already paid to do that, so you have the time. And I think that's the most valuable thing we have is physician time, but we keep throwing that baby out with the bathwater for the sake of coding and paperwork that doesn't matter.
Right. Absolutely. And it sounds, this is the kind of practice that I think most people, when they went into medicine, envisioned. And that's what we used to see in the old days on the doctor TV shows. But obviously, The reality is not the same, but it can be. So that's hopeful for people who want to do this. I think you're setting a good example, and you've got 7 years of experience that's showing that it can be done. It's not just for the elite. So that's great. Tell me, I saw something on your website about the Atlas MD EMR. What is that?
Well, when we started, we had, again, no idea what we were doing. So we built a hodgepodge of software programs to run the office. And before long, we had 9 different programs just running simultaneously for the business of running the business. And that inefficiency was going to threaten the viability of the model. And at 200 patients, we were running around all day long doing busy work. Lab software, faxing, texting, emailing, scheduling, medical charting, inventory, label printing, billing. And we knew you couldn't build a movement on a foundation that was so inefficient. So now we have 5 physicians and 3 staff, all registered nurses. Very efficient per the average doctor. But to get to that efficiency, we decided we had to build our own since we couldn't find anything that really fit the model, different tools, and started that out very slowly, building that for 2-3 years before the movement was picking up momentum and doctors were visiting the office and saying, well, I'm going to run into these same problems. Can I use the software? Eventually, we were able to release that December 2013. Now we have several hundred physicians on it, which is excellent. And it's designed specifically for direct care practice.
Oh, that's great. I noticed you said you have 5 physicians, 3 nurses, and I noticed you didn't mention any back office staff, obviously, because you're not dealing with insurance. You didn't have any specific schedulers. So I kind of think everyone plays their role and then does some of the additional work that is entailed in running an office. So again, just much more efficient that way.
I think so.
I also saw that you ran for lieutenant governor with your father a few years ago back in Kansas.
Yeah, that was something that was on my dad's bucket list to run. He's always been politically motivated. He's actually, I think, a big part of why we tend to buck the system. He was a trash man growing up. He's a lawyer now, so of course I tell people he's still a trash man. It's a less embarrassing profession. But he had a First Amendment case go all the way to the Supreme Court and won. And so I got to watch him kind of fight for what he thought was right through my teen years. And that made, I think, quite the impression. So when we saw the opportunity to think differently, and it was more natural just to take that course. So he wanted to run, and I jogged alongside, and we knew as on the Libertarian ticket that would be an uphill battle, even in Kansas, but it was a great learning opportunity. Very nice. Are we going to see any future runs from you just for advancing the cause of bringing efficiency to healthcare? I don't think I'll run unless maybe on the ticket with somebody else. But we have worked hard in a number of states, as a lot of doctors have. Dr. Phil Eskew, who's also an attorney, is another leader in that world of helping states pass good legislation. In February, I was in Florida and West Virginia talking to their state legislative bodies. We got pro-DPC legislation moved in both states. Hopefully they'll pass when it gets to each governor's desk, basically saying that DPC is not insurance, which is kind of logical but still necessary for the states to say. I help make doctors more comfortable with the idea. But then we go to Madison, Wisconsin Monday to help a discussion there about health care. So it's exciting that more and more states are picking this up and just looking, I think, for what every other industry has to do, a better product at a better price. Great. Okay. Well, thank you very much, Dr. Umbehr. I appreciate you coming on and educating our listeners about the direct practice model. I think it's tremendous. And like I said before, I think it's something that a lot of people wish they could do, and you're showing that it's possible. Where can we find out more if we wanted to about you and your practice? The best website is atlas.md. We have a whole starter packet there for doctors to download free, enrollment forms, vendor relationships, contracts, everything they would need to start a practice. We have a DPC curriculum on that same page so they can go through a 12-step course and learn the basics. You can reach out to us there, Dr. Josh, Dr. Josh, at atlas.md, and then Facebook and Twitter are both at atlasmd. So, we do all the consulting for free. We're very passionate about getting this movement out. We're happy to talk to any doctor who wants to learn more about this model or business or insurance company, because we feel this is just the right thing to do for patients and physicians moving forward. Right. And I think I saw somewhere you also host medical students as well for rotations, correct? Yep. We have Cooper's with us this month from University of Kansas School of Medicine. And so, any students who are interested, we are happy to host them. Of course, I think about any direct care doctor is happy to host them as well. There's 2 great websites to find a list of direct care doctors. IamDirectCare.com and DPCFrontier.com, which is Dr. Phil's website. Perfect. All right. Well, thank you very much. This was informative. Oh, thank you for having me, and appreciate you shedding some more attention on the direct care movement. Thanks for listening to another episode of the Dr. Money Matters podcast. I want to thank my guest today, Dr. Josh Umbehr of Atlas MD. He was really great to talk to about this direct primary care model.
I really didn't know that much about the model other than the few concierge practices I'd heard about previously. But it's great that he was able to take that model and apply it to a more mainstream population. It just goes to show you that there are ways to get around the traditional system in medicine and practice the way that you want to practice. I encourage those of you who are interested in learning more about this model to contact Dr. Josh, and it's amazing that he gives away this material for free and is willing to talk to anyone because he believes in this type of model so passionately. Once again, please leave us reviews on iTunes or wherever you get these podcasts. The better reviews we get, the more this podcast is promoted to a larger audience. So I appreciate it, and I continue to share the podcast with your colleagues and friends. And just let us know if there's any other topics that you would like to discuss. I'm going to try to release an episode per week of the Dr. Money Matters podcast. So if you hit the subscribe button on iTunes, you'll be updated whenever the show is posted. Some of the upcoming topics that I'm going to discuss include contract negotiations, student loans, real estate investing, social media and the healthcare professional, and whether MBAs are worth it, the pros and cons for healthcare professionals. Thanks again for listening, and I hope you enjoy the show.